Hello, everybody. We welcome you to our webinar on current management of retinoblastoma. I would like to introduce you to our wonderful panel members. They are all part of our retinoblastoma team at Children's Wisconsin. So the only financial disclosure is that I'm a consultant with Day One Biopharmaceuticals that makes tovorafenib. That has no correlation with what we are discussing today. The other authors do not have any financial interest. I am the director of retinoblastoma and the interim division chief at Children's Wisconsin. And my panelists include Dr. Amanda Hopp. She is a pediatric pathologist and the MCW tissue bank QC pathologist. Then we have Dr. Nicole Liberio, who is our pediatric oncologist and bone marrow transplant specialist. Then Dr. Kerri Becktell, she's our pediatric oncologist and our cancer predisposition specialist. And Kim Mayer, our wonderful retinoblastoma nurse coordinator. So I'm going to first start off the discussion with talking about the ophthalmic part, and all the other authors will kind of discuss their own portions. So when you look at retinoblastoma presentation, in high-income countries, 98.5% are only intraocular retinoblastoma, and only 0.3% have metastasis. Whereas in low-income countries, approximately 49% present with extraocular RB, out of which approximately 20% have metastasis at presentation. Retinoblastoma is the most common intraocular malignancy of childhood. The mean age of onset is around 18 months. It's unilateral. If it's unilateral, the presentation is around 24 months. If it's bilateral, they present a little earlier, around 12 months. Males and females are equally affected. Around 60% of retinoblastoma is unilateral and 40% presents bilaterally. And the most common presentation is the leukocoria, as you can see in this picture. Now, if you work with pediatricians in your team, it's very, very important for you to spread the information on why a red reflex exam is very, very important. And it is the best way to screen for retinoblastoma. And a lot of other ocular conditions. The American Academy of Pediatrics does recommend that all neonates, infants, and children should have a red reflex exam before discharge from the neonatal nursery and during all subsequent routine visits. In other countries, they have also linked it to immunization schedules where they do a red reflex exam during the immunization. All infants or children with an abnormal Bruckner reflex, which is the other name for red reflex, should be referred. In infants or children in whom parents or observers notice leukocoria, then irrespective of the red reflex exam, they should be referred. And if there's a family history of retinoblastoma, irrespective of the outcome of the red reflex exam, they should be referred. If there's anybody interested, we do have an official recording of the red reflex exam on how to do it, and we are happy to send it to you, and you can voice it over in your languages. The diagnosis of retinoblastoma is mainly clinical, but we do use ancillary testing. When we're looking at retinoblastoma, there are main three components that we look at. This is the tumor, and these are the subretinal seeds, and then there is the vitreous seeds. So when we talk about the classification, it will really talk about all these three components. You will see a lot of red cam pictures, but it's also very, very important to do detailed fundus drawings. And if you do not have red cam, this can be a very good substitute for tumor documenting and monitoring closely. The original classification that was used is the International Classification of Retinoblastoma, where Group A is a small tumor that's less than 3 millimeters. Group B is a tumor that's larger than 3 millimeters or closer to the optic nerve or macula. Group C is a tumor that has seeds that are within 3 millimeters of the tumor margin, and they can be subretinal seeds or vitreous seeds. And then group D is when there is diffuse seeds that are more than 3 millimeters away from the tumor margin. And E is when you have extensive retinoblastoma with neovascular glaucoma or signs of invasion. Just similar to other tumors have moved to TNM classification for uniform reporting, retinoblastoma finally has a TNM classification. It is kind of similar to the ICRB classification, at least for the initial phases, but then you also have the nodes and the metastasis. Though as ophthalmologists, we are usually used to using the international classification, I would recommend that in addition, we also do the TNM classification. And this is how the TNM classification will look like. So when you look at the growth patterns, there are three main growth patterns: exophytic, which has a lot of retinal detachment; endophytic, that grows into the vitreous cavity and has a ton of vitreous seeds; or diffuse infiltrating, where the retinoblastoma actually grows along the retinal layers, sometimes causing like a uveitis-like picture. The diagnosis, like I said, is mainly clinical, but we use a lot of ancillary testing, out of which the ultrasound is the most important. On ultrasound, you're really carefully looking for the hyperreflective spikes that suggest calcification. And then if available, we do a fluorescein angiography, which will show the tumor vasculature. The other reason why fluorescein angiography is very important is to look for the neovascularization of the iris, which will put the classification as a group E according to the international classification. Of course, we do the magnetic resonance imaging when available. It really doesn't help in diagnosis beyond a level, but it is mainly to look for the pineal gland, to look for pineal tumors, pinealoblastoma, and also to look for optic nerve and choroidal invasion. If available, we also like to do optical coherence tomography, which really can show sometimes subtle vitreous seeds that you don't see otherwise clinically. And it is also useful for detecting occult retinoblastoma that you would have otherwise missed. This is a patient with a family history of retinoblastoma. And on fundus examination, you cannot even see the tumors. But if you do the OCT, you see a very tiny tumor right there, and I'm hoping you can see my arrow. And in the left eye, you see a tumor right there. So optical coherence tomography can be very useful for detecting these small tumors and even for detecting small recurrences. This is a retinocytoma. The older terminology was spontaneously regressed retinoblastoma. And this is how they present, and we consider it to be a benign variant of retinoblastoma. And it kind of looks like a treated retinoblastoma, where you have a little chorioretinal atrophy around it. It will be partially calcified. And if you're unsure, just monitor closely and make sure there's no change over time. But the genetic implications of retinoblastoma are identical to retinoblastoma. So you have to test for germline retinoblastoma. And if there is a family history, then you have to screen the entire family. Moving on to management of retinoblastoma. Before we talk about management, I briefly want to touch about the regression patterns of retinoblastoma. Following treatment, there are mainly 4 types of regression. There is also a type 0, where the tumor just disappears. Type 1 is where you see 100% calcified tumor. Type 2 is a completely non-calcified tumor. Type 3 is a partially calcified tumor, where portions of it are calcified and portions of it are not. And type 4 is where it becomes a flat scar. Coming to treatment of retinoblastoma, you can do local therapy, which includes laser, cryotherapy, and transpupillary thermotherapy. Chemotherapy, which is the main modality of treatment. It can be local, it can be systemic, or it can be intra-arterial. And when it comes to radiation, you can do a local radiation, which is plaque brachytherapy, or you can use external beam radiotherapy or proton beam radiation, and enucleation or sometimes accentration. When you look at transpupillary thermotherapy, it is used as an adjunct to systemic chemotherapy or intraarterial chemotherapy. It's also useful for small recurrences. In a transpupillary thermotherapy, you're using the 810 nanometer laser, preferably with a large spot laser. And you are not photocoagulating the tissues, but you're mainly increasing the temperature of the tumor, causing regression. So when you're doing the laser, you'll actually see just like a mild haziness, just like a slight gray appearance. You don't want to see the photocoagulation. If transpupillary thermotherapy is not available, or in a very lightly pigmented eye, you can also use the conventional green laser, which is the 532 laser photocoagulation. Cryotherapy also is used along with systemic chemotherapy or intraarterial chemotherapy. It's mainly useful for anterior tumors and anterior recurrences. Here you can see a large recurrence that was successfully managed with just cryotherapy. When it comes to systemic chemotherapy, Dr. Liberio is going to discuss more in detail about the chemotherapy regimens, but it is primarily used for bilateral retinoblastoma. We use it for familial retinoblastomas because these kids are at risk of developing more new tumors, and post-enucleation for high-risk features. Dr. Hopp is going to discuss all the high-risk features, and if post-enucleation there are high-risk features, then also we considered systemic chemotherapy. Intraarterial chemotherapy, we have had significant experience over the last 15 years on intraarterial chemotherapy, where the catheter is fed through the femoral artery, you go all the way up to the ophthalmic artery, and you give chemo. This is a child with unilateral multifocal retinoblastoma. She did have germline retinoblastoma, but the other eye was spared. And following intraarterial chemotherapy, you can see a very nice response, and the macula is spared. So this child has good vision potential. Again, this is showing the catheter, and before actually injecting chemo, they'll do a fluoroscopy, and it's showing the nice vasculature in the eye. Again, more examples of extrafoveal tumors that respond nicely to intraarterial chemotherapy with good vision potential. The advantages of intraarterial chemotherapy is that there is minimal side effects. There is only a transient lowering of the WBC count. You still have to do weekly counts because you will see a dip in the counts. There are lower rates of hospitalization for the same reasons, that the WBC count doesn't go down too much. The other advantage is that the dose delivered to the eye is very high because it's directly injected into the eye, and there's low risk of chemotherapy resistance. The disadvantages are that in 3 to 5% of cases, the ophthalmic artery does not arise from the internal carotid, and the interventionist has to modify their plan. It is a neuroinvasive procedure, so there is a theoretical risk of stroke. Also, the disadvantage is that there is no systemic protective effect. So if you were having high-risk features and there's risk of metastasis, it would not protect against that. And theoretically, it does not protect against spinaloblastoma and second cancers, which some people believe the systemic chemotherapy might protect. The main side effect is the risk of ophthalmic artery stenosis. Compared to when this procedure was first started, the incidence of ophthalmic artery stenosis has gone down because the technique has been modified. Your interventionist would know that they don't actually enter the ophthalmic artery. They sit just at the ostium of the artery, so you're not disturbing the endothelium of the ophthalmic artery. This is what a ophthalmic artery stenosis would look like. This is a partial obstruction, so you can see the significant choroidal ischemia. Intravitreal chemotherapy is being done for the last 15 years almost. It's really very beneficial for recurrent or persistent vitreous seeds after other treatments. Here you can see extensive vitreous seeding that responded to intravitreal chemotherapy. And in the bottom picture, there are just few seeds that occurred that responded to just a single injection. When you're doing intravitreal injections, it's very, very important to be careful and use very safe technique because this can cause tumor dissemination if not done in a correct fashion. So our procedure is that we do a good ultrasound biomicroscopy to make sure there's no ciliary body involvement. You choose a quadrant that is furthest away from any active tumor. After that, we do an AC paracentesis. The first time we are doing for a child, we will send the AC fluid for cytology to make sure there's no active tumor, or you can also use the OCT to make sure there's no anterior seeding. Once you are sure that there is no anterior involvement, then you go ahead, inject with a 32 or a 33 gauge needle. And as you're coming out with the needle, you press cryotherapy at the needle entrance. And after the cryo has started freezing, you remove the needle and you do a triple freeze thaw cryotherapy. So in case there are any cells that are trying to be released from the eye, the cryotherapy is going to treat it immediately. Following that, you shake the eye to distribute the chemo. And I also recommend that you do a good peripheral scleral depression right at the point where you have injected to make sure that no seeds are actually sticking to that point. So again, intravitreal chemotherapy is because this technique was recommended by Dr. Monet in Switzerland. And in their original paper, they reported on 122 intravitreal injections with a globe retention rate of 87%, but approximately 43% of them had salt and pepper retinopathy. And this is what salt and pepper retinopathy looks like. Right at the quadrant of entrance, you will see the salt and pepper retinopathy, which we mainly saw with melphalan. Now with the use of topotecan, you don't see it as much. And we have actually currently started using higher dose topotecan. We're using 90 microgram topotecan. This is a child with unilateral retinoblastoma that had a nasal subretinal seed that had failed multiple rounds of cryotherapy. And then after 2 doses of 90 microgram topotecan, you see that the seed is completely resolved. This is an unfortunate patient. She's a 21-year-old who has had multiple recurrences of the macular tumor. Her other eye is enucleated. And during this most recent recurrence, she was treated with 3 doses of 90 microgram topotecan. In addition, we also did some laser to prevent any further recurrences because this was her 4th recurrence after age 10. This is another child, again, monoocular because the other eye was enucleated, an extensive subretinal seeding that was treated with melphalan and topotecan, and also TTT was done along with it to solidify the scars. Moving on to plaque brachytherapy, it can be done for recurrent tumor or subretinal seeds that are not amenable to other treatments. The disadvantage of plaque brachytherapy is that it affects the vision significantly because it can cause radiation retinopathy, radiation maculopathy, and radiation papillopathy. External beam radiation is reserved mainly for advanced bilateral disease to avoid a bilateral enucleation. And when possible, we try to do the proton beam radiation. So there's less dose to the orbital bones, hopefully minimizing the risk of second cancers. Coming on to enucleation, we use it mainly for unilateral advanced group E disease, recurrences that have failed all other treatments. You have to be very careful to get a very long section of the optic nerve because if the optic nerve is infiltrated, you want to go beyond the cut resection margin. The implants available are acrylic, hydroxyapatite, and polyethylene. If a child has had extensive treatment, especially after chemotherapy, then we also use an amniotic membrane along with the enucleation, and that has minimized the number of wound dehiscence and implant exposures. So this is a Medpore implant, and you can see all the muscles have been sutured to the Medpore implant. And then we have placed the amniotic membrane right over it, and then we close the tenons in layers, and then we place the conformer and put a heavy patch over the eye. The next unusual situation you might face is cavitary retinoblastoma. The disadvantage is that these ones only have a slight clinical response to chemotherapy. As you can see in this, as you can see in this image, you can see those cavities in the tumor. It has been noted that it might have a favorable long-term outcome in spite of only mild tumor regression because it's thought that it might be slightly a benign variant of the tumor. But you've got to watch for these cavities that you can see on OCT, you can see them on ultrasound, and of course you'll see them clinically also. I'm going to just talk about a quick case. This is a 4-month-old with unilateral with no family history. So whenever you have a very young child with very aggressive disease, you have to think about the MYCN amplification tumors. They are usually not amenable to treatment and often need enucleation. The one thing you have to mention to the family is that fortunately they're not hereditary. So there is not a risk of other siblings having retinoblastoma or the future children having retinoblastoma. Moving on to orbital retinoblastoma, this is a child that presented with extraocular extension at presentation. This is the latest report from the Retinoblastoma Consortium, and they showed that patients who underwent only chemotherapy and surgery had a 1.8 times higher chance of death compared to those receiving multimodal therapy, including chemotherapy, surgery, and external beam radiation. So that is the recommendation, that you use all three, use surgery, chemo, and radiation for the management of orbital retinoblastoma. And the patients who underwent primary surgery for retinoblastoma with extraocular extension had a 6.5 times higher risk of systemic metastasis compared to those who received neoadjuvant chemotherapy before surgery. So this is from Dr. Santosh Honavar in India, and I would recommend that people follow a version of this protocol where initially chemotherapy is done, followed by surgery, followed by more chemotherapy, followed by external beam radiation. Quickly about a newer clinical trial that we are doing. This is, we have completed phase 1 of the trial. This is a small device that releases chemotherapy. It is glued onto the episclera and it releases chemotherapy. These are some results. These are patients that have failed other treatments and post-chemotherapy show a very nice response. You see a patient with tumor, subretinal seeds, and vitreous seeds showing a nice response to the intraarterial chemotherapy. In the last 1 minute, I'm going to quickly talk about how some other tumors can look, other diseases can look very similar to retinoblastoma. Here you have 3 patients that present with leukocoria, and one is retinoblastoma, one is persistent fetal vasculature, and one is Coats, which is which. The bottom one is PFV, which is usually sporadic at birth. Retinoblastoma is 10% familial, and the Coats, which usually presents at 5 years, and it's usually unilateral. And you can use fluorescein angiography. In retinoblastoma, there's early filling, late leakage. In PFV, usually you see hyperfluorescence, but you don't see leakage. And in Coats disease, you see the characteristic telangiectasias. The ultrasounds can also be helpful. In retinoblastoma, you see a solid mass. In PFV, you just see the stalk. And in Coats disease, you usually see a macrocyst and a retinal detachment. This is a newer ultrasound imaging that we can use. It's called microflow imaging, and really shows the vasculature that can help in the diagnosis. And when you're unsure, you can also send the aqueous fluid to look for gene mutation if you're unsure of the diagnosis. I pass it on to Dr. Hopp, our pathologist.
My name is Amanda Hopp. I am going to talk a little bit about the pathology of retinoblastoma today and what the role of the laboratory is in helping care for these patients. So retinoblastoma at its core is considered the small round blue cell tumor of the eye. It's derived from the retinal precursor cells, so it's a very primitive tumor. The role of pathology, and again of the laboratory primarily, is to ensure proper specimen processing, as well as convey important information about the histologic features such as grading and staging. For specimen processing, I'm going to focus on enucleation specimens. And so one of the first things that we do in the laboratory does with enucleation specimens is actually, even before you put it into formalin for fixation, we often will look to procure fresh tumor for potential molecular studies. Sometimes research protocols require fresh tumor. And so this is one of the first things we do, and then we often will freeze it or put it into the appropriate medium. I say it's one of the first things because even before you procure fresh tumor, what you want to do first is actually take a cross section of that optic nerve margin that was discussed previously, because once you start actually handling the tumor, these tumors are really friable and those little cells tend to get everywhere once you start touching it, and you don't want to contaminate your optic nerve margin. So that is truly the first thing that's done, is taking that cross section, putting in a separate cassette, letting that fix, then potentially procuring fresh tissue as needed, then putting it into formalin, allowing it to fix appropriately. In most protocols say 48 hours. That's typically what the practice is, but really the goal is to make sure it's fixing so you get nice sections. So whatever that means for your laboratory. After fixation, then we start handling the specimen from a histology standpoint. We do our best to orient the globe based on external structures such as the extraocular muscles. And then that way we can try and get a sense of where the tumor is located. I say we do our best because this is often easier said than done based on just where things are located and how much of the muscle you get, but truly you do your best. And then we do utilize transillumination to, again, see where the tumor is, see where most of it is located and where the tumor base is, because that becomes important then when you're sectioning. And one of the most important sections that we obtain in the laboratory is something called the pupil optic nerve, or the PO section. And what this is, as you can see from the pictures here, is essentially doing your best to get as much of the tumor and or the tumor base in one large cross section with the pupil and the optic nerve, where the optic nerve enters the back of the globe, and where the optic nerve head is. And that way we can actually get a good indication of important relationships between the tumor and those structures, which I'll go into a little bit later. And then after you get that nice PO section, we put through additional sections. Our practice, and really the practice of most institutions, and what my recommendation would be, is to submit the entire globe, just because some of the other important histologic features can be a little bit focal in nature. So again, getting that nice PO section and then putting through the rest of the globe. This is what some gross pictures of those PO sections look like. Again, you have the anterior structures and the pupil here with your optic nerve as it's entering the back of the globe here, and then the relationship with the tumor, again, as much as you can get within that section. And then just some first sections of what the histology would look like for those PO sections. And then we as pathologists will cut further into the block to, again, really capture where that optic nerve head is entering the back of the globe and where that sclera is interrupted. Because again, that becomes important for some of the high risk features that we convey to the clinical team. So for example, this left picture, the picture on the left here, would definitely need levels and to cut into the block because we're really not quite capturing that yet. From a histology standpoint, as I mentioned, this is really kind of the classic small round blue cell tumor of the eye. And so with that, these are some pretty characteristic pictures of what that looks like. So on the left, we can see retinoblastoma presenting in sheets of these tumors that have a high nuclear to cytoplasmic ratio, fine, evenly dispersed chromatin. Those are all features of immaturity when we think about cells. These tumors also often present with necrosis, as you can see here, frequent mitotic figures, and apoptotic or karyorectic bodies. Again, just really classic of the immature small round primitive tumors. And then really what we're seeing often in these tumors as well, and what's kind of presented in textbooks, is rosette formation, which you can see here on the right. We have a variety of rosettes that you can see here, but this is something that we do look for because from a grading standpoint, just summarized here, grading is really thinking about how differentiated is the tumor. Is it really close to making what looks like retina, or can you not even tell that it's trying to make retina, and everything in between? Again, where the amount of rosette formation becomes particularly important to evaluate. And then really one of the other very important roles of pathology is staging and giving a sense of the extent of tumor involvement, which structures are involved. And with that, then we're conveying important information about the high-risk histologic features, which again, I'll talk about a little bit. I'll say with the caveat that as you're looking out in the literature in different institutions, there is some variability in what is the definition of a high-risk histologic feature. You'll see some included that are not included in other papers. So what I'm going to present here today are the ones that are pretty consistently considered high-risk features across the board. Again, with the caveat that there may be a little bit of variability with some additional. So one of the things that we look for is something called choroidal invasion. So looking for involvement of that one of the inner layers of the globe by tumor. And we as pathologists then divide this into focal versus massive, with the definition of massive listed there. And really massive is any amount greater than 3 millimeters in any way, shape, or form, or having full thickness choroidal involvement, even if it's just a focus. If it's full thickness, that also counts as massive. And then anything less than that is considered focal. And this is what choroidal invasion looks like. So we have our tumor here kind of tracking along, again, the inner layer, inner part of the choroid. Here's our choroid stroma here. And often we'll see it tracking along, but really what you want to see for good choroidal invasion is it actually breaking through that basement membrane into the choroid. So these foci here would actually be considered choroidal. If this picture is all I had, this would be considered focal. And then again, if you have more than 3 millimeters or added up and it's more than 3, that's considered massive. And then here's just an example of what that full thickness choroidal would look like. Again, now we're breaching that basement membrane and getting full involvement of the choroidal layer there. That again would be considered massive. And then one of the other really important things, again, kind of calling back to that PO section and why it's so important, is looking for involvement of the optic nerve head, or you'll also hear this called lamina cribrosa evaluation. And the reason that is because the area here where the optic nerve enters the back of the globe, you see interruption of the sclera to allow the optic nerve to go there. And this is the optic nerve head, and this area is called the lamina cribrosa. So what we're looking for as pathologists is the tumor involving the optic nerve head? And if it is, where in relationship to the lamina cribrosa is it involving? Is it in front of, within, or behind, which would be pre, intra, and retro or post-laminar, respectively. And that's particularly important because retro or post-laminar involvement is considered a high-risk feature. Whereas the other two would not. So again, being able to have that good section, evaluate the tumor and what its relationship is to that lamina cribrosa, if it is invading the optic nerve head, is really key, because being able to say if it's retro or post is important. And then from a choroidal invasion standpoint, again, it was focal versus massive. If you have massive choroidal invasion, that's also considered a high-risk feature. We also look for if there is anterior chamber or anterior segment involvement, because that's also, for the most part, usually considered a high-risk feature. So again, this can include things like anterior chamber seeding, involvement of the iris, which actually this picture is showing, and almost a little hard to tell because the tumor has actually involved it so much and expanded it, it's almost like obliterated the architecture of the iris. But again, those are just things that we think about and is considered a high-risk feature because now it's indicating like the tumors may be showing some more aggressive features. Scleral invasion is another thing that we look for. And so that is now saying, you know, the tumor has gone through the choroid now into the next layer. And any kind of scleral invasion is considered a high-risk feature. We as pathologists look for the extent of scleral invasion. Is it the inner third or the outer layers? But for the purposes of a clinical importance, any type of scleral invasion is considered a high-risk feature. And then not surprisingly, once you start invading outside of that, extrascleral and extraocular involvement is of course also going to be considered a high-risk feature. This is just a gross picture of what that might look like where we have tumor outside of the globe. And then a histologic picture of that as well, tumor within, but now also extending in to the extraocular structures. And then finally, really calling back to, again, why it was so important to take that optic nerve margin separately before you do anything else. Having optic nerve margin involvement is also considered a high-risk feature. What we look for, you can see involvement in kind of like a perineural fashion, which is what we're seeing here, but you can actually also see it in the structures around it or within the actual parenchyma of the optic nerve. All of it counts as optic nerve margin involvement. And again, that's also important because it's considered a high-risk feature. This is just a summary of what was already kind of talked about, the TNM classification. This is now specifically the pathology TNM classification. And I won't go into the details, but really just highlighting here that, again, some of those high-risk features also correlate to a higher stage from our pathology staging. And then we also look at lymph nodes if they're submitted and try and give a sense of metastatic disease, again, if it's applicable to that specific case.
And my name is Nicole Liberio. I am a pediatric oncologist at Children's Wisconsin in Milwaukee. And my role today will be to discuss the role that the pediatric oncologist plays in retinoblastoma care. Before we get into my role, I think it is really important to point out that optimal care for patients with retinoblastoma requires multidisciplinary treatment involving ocular oncologists, pediatric oncologists, endovascular neurosurgeons, pediatric neuroradiologists, geneticists, specially trained pathologists, psychologists, and social workers. Dr. Ramasubramanian earlier gave a comprehensive overview of the management of retinoblastoma, but now I would like to delve a little deeper into the role of systemic chemotherapy. In the 1990s, systemic chemotherapy became a mainstay of therapy for certain patients. Next slide. Systemic chemotherapy is utilized as adjuvant treatment following enucleation in patients with high-risk features, for disease reduction as part of an ocular salvage approach, and for treatment of extraocular, metastatic, or trilateral retinoblastoma. Next slide. The first indication for chemotherapy is as adjuvant treatment following enucleation. The Children's Oncology Group study ARET 0332 prospectively studied the role of adjuvant chemotherapy in 321 eligible children with newly diagnosed enucleated unilateral retinoblastoma. Patients with high-risk features on histopathological review receive systemic chemotherapy with 6 cycles of carboplatin, etoposide, and vincristine administered every 4 weeks with a 2-year EFS rate of 96%. Chemotherapy can also be used for disease reduction as part of a conservative ocular salvage approach. The backbone of chemo reduction has generally been the same regimen we just discussed of carboplatin, etoposide, and vincristine, but there are also alternative regimens to be considered for certain patients. The less toxic combination of vincristine and carboplatin can provide disease control for certain patients, particularly group B eyes. However, overall ocular salvage appears to be superior when etoposide is included in the regimen. Another option to replace etoposide is to replace etoposide with topotecan. There was a single institution study using this method that did achieve similar results to the CEV regimen. And then lastly, I just want to point out that the prognosis for patients with group E eyes who are treated with systemic chemotherapy and local control measures is very poor without the use of radiation. The use of prolonged systemic chemotherapy for group E eyes to avoid or delay enucleation has been associated with lower disease-specific survival. This figure just shows the success rates of systemic chemotherapy, specifically that CEV regimen by eye group. You can see that systemic chemotherapy works very well to salvage eyes with group A through group C disease, but does have a high failure rate for those group D eyes. There is a current Children's Oncology Group study, ARET 2121, open that seeks to address inferior outcomes in group D eyes by adding intravitreal chemotherapy to systemic chemotherapy for the management of vitreous seeding. Patients enrolled in this study will receive systemic chemotherapy alone for cycles 1 and 2. For cycles 3 through 6, patients will be eligible to receive intravitreal melphalan and/or focal therapy, such as laser or cryo, if they meet criteria, in addition to that systemic chemotherapy. Then for after cycle 6, patients who meet criteria for injection may receive additional doses of intravitreal chemotherapy for up to 6 total per eye. We at Children's Wisconsin are one of the centers who currently have this clinical trial open and enrolling, so please don't hesitate to reach out to us or any enrolling center if you think you may have an eligible patient. Lastly, systemic chemotherapy is necessary in the treatment of extraocular disease, which may be localized to the soft tissue surrounding the eye or to the optic nerve but beyond the margin of resection, or may have further extension with progression into the brain, meninges, seeding of the spinal fluid, and distant metastatic disease. So this also includes patients with that trilateral disease. Orbital retinoblastoma occurs as a result of progression of the tumor through the emissary vessels and sclera. For this reason, transscleral disease is considered extraocular and should be treated as such. For orbital and local regional disease, up to 85% of patients can be cured with a combination of systemic chemotherapy and radiation. The recommended treatment is per the COG trial ARET 0321, which I have referenced here. Patients with stage 2 or 3 retinoblastoma will receive 4 cycles of vincristine, cisplatin, cyclophosphamide, and etoposide, followed by involved field radiation of 45 gray. And the 3-year EFS and overall survival on this study were 88% for that group. Patients with stage 4A or metastatic and stage 4B trilateral retinoblastoma also received 4 cycles of induction therapy. Patients with more than a partial response underwent autologous hematopoietic cell transplant, and patients with residual tumor after chemotherapy received radiation therapy. You can see here that the 3-year EFS and overall survival for the metastatic group was 76%, but the outcomes for the trilateral group are still quite dismal, with an EFS of 14% and overall survival of 12%. So we always counsel our patients undergoing systemic chemotherapy on some of the following drug-specific side effects. So cisplatin and carboplatin can cause ototoxicity and nephrotoxicity. Vincristine can cause peripheral neuropathy. Cyclophosphamide can cause hemorrhagic cystitis. And etoposide can cause anaphylaxis and secondary leukemias. As we just reviewed, platinum agents are the backbone of systemic retinoblastoma therapy. Hearing loss constitutes a serious and permanent side effect of platinum chemotherapy, with cisplatin being the worst offender. Carboplatin has a lower impact on hearing, though hearing loss is still reported in up to 20% of patients receiving the carboplatin doses in the CEV regimen. The incidence rate of ototoxicity in children is higher than in adults, and even mild hearing loss may severely affect learning, development, and quality of life in young children, especially those in whom vision may be compromised. Key consonants are heard at high frequencies, so their loss is debilitating, particularly in young children in whom speech has not yet developed. This is a study from St. Jude that was published in 2012 and looked at the incidence and risk factors of ototoxicity in children treated for retinoblastoma. The study included 60 patients with a median age of 8.6 months who received 8 cycles of carboplatin. The incidence of hearing loss was 20%, with age at the start of treatment being the only significant risk factor. Patients ages less than 6 months old were 21 times more likely to have sustained hearing loss. And patients less than 6 months had an incidence of 39% for hearing loss, and this dropped to 8% if 6 months or older. Next slide. In 2018, the New England Journal of Medicine published the results of SIOPEL-6, a randomized phase 3 trial designed to investigate the question of whether sodium thiosulfate would reduce the incidence and severity of hearing loss caused by cisplatin. Their results demonstrated hearing loss of grade 1 or higher in 33% of the cisplatin sodium thiosulfate group, compared to 63% in the cisplatin alone group. So we do have some practice recommendations for ototoxicity prevention. We recommend the addition of sodium thiosulfate, if available, to cisplatin-containing regimens. We do recommend inpatient administration with scheduled antiemetics because it is highly emetogenic. We recommend sedated hearing exams prior to each cisplatin-containing cycle with dose adjustments per protocol. We also recommend sedated hearing exams prior to each carboplatin-containing cycle with dose adjustments per protocol as stated here, and the addition of sodium thiosulfate if any hearing loss is noted. Of note, though, for those patients who are less than 6 months old at the time of diagnosis or at the time of getting systemic chemotherapy, you could consider adding sodium thiosulfate empirically from the start of chemotherapy, given their higher risk of hearing loss. And just really quickly to end, I want to switch gears and briefly discuss the future of precision medicine in retinoblastoma. So the goal of precision medicine is to identify specific genetic changes within each individual tumor that may allow for an individualized treatment approach. However, in retinoblastoma, we do not biopsy tumors given the proven risk of causing metastatic spread. And so instead, our diagnosis is always made by direct visualization. Of course, the lack of a tumor sample is then a barrier to precision medicine. So in recent years, however, it has been discovered that circulating tumor cells can be identified within the aqueous humor of the eye. So this allows us to not only confirm the diagnosis or the presence of active disease, but also allows us to identify certain prognostic features or potentially treatment targets within an individual's tumor. Fundoscopy is sometimes insufficient to discern whether tumors are inactivated following treatment. So this study published in 2023 demonstrated a method of detecting active disease via aqueous humor liquid biopsy, and thus showed that the method can be used to complement fundoscopy when following treatment response. The aqueous humor can also be used to identify prognostic indicators. So, for example, 6P gain has been associated with a tenfold increased risk of enucleation. In a nucleated eye, 6P gain has been associated with aggressive histopathologic features, including focal invasion of ocular structures. We all believe there is continued work to be done with aqueous humor liquid biopsy and identifying further genetic targets with prognostic and therapeutic implications. To that end, we currently contribute to a biorepository at CHLA and are in the process of opening a local biorepository. We're happy to provide more information on either to anyone who's interested. And then these are just references.
So, as it has been mentioned, my name is Kerri Becktell, and I am a pediatric oncologist here at Children's Wisconsin and the director of our cancer predisposition program. So, I'm going to switch gears a little bit and focus on discussing the aspects of care for retinoblastoma patients related to genetic predisposition. And so a first question, this is not a real polling question, but just something I want to think about when you have a patient, which patient should undergo genetic testing for evaluation of hereditary retinoblastoma? Should it be new patients with unilateral disease and no family history? Patients with bilateral disease and no family history? New patients who have unilateral disease and family history of retinoblastoma, new patients with bilateral disease and a family history, children of parents with a history of retinoblastoma who do not yet have retinoblastoma themselves. And the answer is all of the above. So our summary is that any of these patients falling in this category, we would recommend germline genetic testing. And we're going to kind of talk through the reasons for that. So we know that hereditary retinoblastoma is caused by a pathogenic variant in the RB1 gene that is inherited in an autosomal dominant fashion. About 45% of children with retinoblastoma are estimated to have a germline pathogenic variant in RB1. And the presence of having an RB1 germline variant leads to an increased risk of greater than 90% chance of development of retinoblastoma in one or both eyes over the course of a patient's life, typically in early childhood. There is also a 2 to 3% risk of development of trilateral retinoblastoma with a tumor in the pineal gland or other midline CNS structures. The other risks that go along with having hereditary retinoblastoma are for other malignancies later in life, including osteosarcoma and melanoma. These risks are even more increased in patients who have hereditary retinoblastoma and receive external beam radiation, particularly in those radiation fields. And that's one of the drivers for us to find treatments that help control retinoblastoma without the use of external beam radiation when possible. RB1 germline genetic testing can be done on blood, saliva, or on fibroblasts. Typically, fibroblast culture is not necessary, and you can get the answer you need from blood and saliva. Though, if your clinical concern is high, but initial testing on blood or saliva is negative, it is really important to be aware of the chance of mosaicism, where you have that change in some of your DNA, but not all of it. And so testing on other tissue types can be helpful. This is a figure from a recent publication that highlights pediatric focused cancer predisposition guidelines that I really like. So on the left, for thinking about individuals presenting with bilateral or multifocal disease, we assume that these patients have hereditary retinoblastoma based on this presentation. But we would start by doing germline testing of the blood or saliva. And if a germline pathogenic variant was not identified, at that point, tumor analysis, if available, might help inform the likelihood that the initial testing missed a germline variant or there is mosaicism. And on the But either way, even if we don't have that tumor sample, but a patient has bilateral disease, we would screen them and treat them as if they have hereditary retinoblastoma. For patients presenting with unilateral disease, they may or may not have hereditary RB. And so if initial germline testing is negative, again, tumor analysis, if available, may be helpful to distinguish between sporadic RB from a missed germline or a mosaicism picture. And intraocular exams at that point are really based on clinical presentation and how their tumor is responding. Analysis of a nucleated tumor tissue, if available, can be informative in a lot of different ways. And here we send all of our enucleated eyes for genetic sequencing through the COG's Project Every Child, but it can be really helpful. If two separate RB1 mutations or variants are clearly identified in the tumor, germline sequencing can be focused on those targeted mutations. And alternatively, if a germline test was previously negative, but you see two of these different variants within the tumor, that can help you in retrospect go back to help understand why your initial testing may have missed it, or to help confirm the presence of mosaicism. Frequent examination for patients with hereditary retinoblastoma is critical to early identification of tumors that are amenable to local treatments. So these guidelines, which really focus on initial surveillance for unaffected children at increased risk because we know they have hereditary retinoblastoma, harmonize with the consensus guidelines from the American Association of Ophthalmic Oncologists and Pathologists that are considered for the children considered at high risk in their guideline. Once an intraocular tumor is identified, the screening really depends on the treating team and the trajectory of the tumor. So it may be more frequent than this cadence, but this is kind of the minimum amount you would want to screen a patient who had hereditary retinoblastoma. Surveillance for trilateral retinoblastoma begins with a brain MRI at the time of diagnosis. Of the few patients who do present with trilateral retinoblastoma, 50% will have those pineal tumors present at the time of their initial intraocular retinoblastoma diagnosis. We know that the incidence of trilateral disease is higher in patients with hereditary retinoblastoma than those without, but it is still a relatively low risk. And so the most recent guidelines suggest MRIs every 6 months until age 4, which is what we practice here at our institution. Screening for non-ocular tumors includes focus on screening for osteosarcoma, which is the most common malignancy besides retinoblastoma seen in hereditary RB, and melanoma. Include regular history and physical exams. These are the highest yield ways to identify a second tumor or malignancy in a patient with hereditary RB. Imaging of a spot with new pain or persistent pain with MRI or a biopsy of any skin lesions that look suspicious or are changing over time is critical for treating providers to be able to take action on. Skin exams by both pediatricians and dermatologists to help identify at-risk skin lesions can be helpful. And we recommend having patients establish with a dermatologist as they're reaching the age where their parents are not bathing them every day to be able to notice changing or new skin lesions. There's ongoing debate and a lack of consensus when we think about screening MRIs for asymptomatic patients looking for osteosarcoma. Obtaining a whole body MRI for some sarcomas is recommended in other cancer predisposition syndromes, but the data that is specific to identifying pre-symptomatic osteosarcoma in patients with hereditary retinoblastoma does not currently clearly support benefit of doing this. The largest study that performed whole body MRIs in a cohort of patients with hereditary RB was completed at Memorial Sloan Kettering in New York. and they did not identify any asymptomatic osteosarcoma in any patients who obtained screening over a period of 10 years. There are also very real risks in identifying abnormalities on whole body MRI that do not turn out to be cancer or malignancy, yet put patients through multiple additional procedures as part of a workup that often involve invasive things. So, our practice here is to have a risk benefit discussion with families when patients reach an age of not needing sedation for MRIs. But when parents ask what my recommendation is really to focus on the clinical symptoms and exam as monitoring, that is the tried and true way of identifying these tumors that we know is successful. It's also critical to assure that hereditary retinoblastoma patients receive education and support as they transition out of pediatric medical care into adult healthcare systems. This includes ensuring that their genetic testing is informative and inclusive as our technologies advance quickly over time, that they know the risks for other malignancies and the warning signs and symptoms to be aware of, and maybe most importantly, that they understand the risks of passing this genetic change onto future offspring and the options for testing and screening that they can advocate for themselves and their future children if or when the time comes. Which leads perfectly into the next few slides of what I'm going to talk about in my section of this, which is focusing on prenatal screening options for patients with hereditary RB. We know that understanding retinoblastoma risks and identifying tumors early leads to improved eye outcomes, which is our main focus. So if family planning is done in the preconception phase, preconception planning, there is the ability to have embryo testing completed for RB1 pathogenic variants and implant only embryos that are negative for that variant via IVF. This is one way that parents are able to definitively understand the risks for their future children. Alternatively, if pregnancies occur naturally to parents who have a history of hereditary retinoblastoma, there is in utero testing options in the first and second trimesters that can be done to help inform the need for screening both in utero and after birth. We now have the ability to screen for and identify retinoblastoma tumors prenatally, which can help guide delivery planning and postnatal care to optimize those eye outcomes. And the first step in utilizing this technology is to appropriately identify patients who will benefit from it. So this includes babies with a known RB1 germline variant that were identified through some of those early trimester genetic testing, or if we knew that from pre-implantation genetic testing. The other babies who have a real potential to benefit from this screening include babies who have not yet had genetic testing done, but have a 50% of a chance of inheriting that RB1 pathogenic variant from one of their parents. And so once the at-risk babies have been identified, prenatal screening can begin between 33 and 34 weeks gestation, with ultrasounds performed by ultrasound techs who have received training and repeated every 2 to 4 weeks, as we know that retinoblastoma tumors can grow very rapidly in size. If tumors are identified, a discussion between the retinoblastoma team and the mother's OB physician should occur to determine if an early term delivery is medically appropriate. And then eye exam would occur right after birth with local treatment, as should that confirmatory genetic testing if needed. Closed postnatal follow-up exams will be determined by tumor burden and the tumor trajectory. If no tumors are identified on that prenatal screening, delivery can occur as directed by the OB, and an eye exam should occur right after birth and continue on that hereditary RB screening protocol until genetic testing results are available to determine if that continues to be necessary or if that baby is negative and can stop screening. Here's 2 examples of prenatal screening images that Dr. Ramasubramanian Ramasubramanian provided me. This was a baby who was identified as being at risk, and mom started undergoing fetal ultrasounds every 2 weeks, starting at 32 weeks gestation. During the screening, intraocular tumor was identified in the left eye at 34 weeks, and again here at 36 weeks. And there was also a second small tumor identified in the right eye that is not pictured here. Given the presence of tumors, mom was induced at 37 weeks, and the tumors were able to be treated with local measures. So, in summary for my section, all patients with a retinoblastoma diagnosis need to undergo genetic testing for the presence of a germline pathogenic variant in RB1. Vision and eye outcomes are positively impacted when appropriate screening occurs for children with hereditary retinoblastoma, and awareness of subsequent malignancy risk is critical to early identification and treatment later in life. The importance of education for patients with hereditary RB as they become adults cannot be understated, and knowledge of inheritance patterns and need for screening can dramatically impact early identification and screening options for their future offspring. Providers caring for retinoblastoma patients really, if able, will benefit from partnering with a cancer predisposition team who can help make sure that comprehensive care is ongoing as we exit early childhood and move into adolescent and young adult, as to be able to help support those patients as they age, because hereditary retinoblastoma is a lifelong condition, and when we're out of the retinoblastoma risk, there's still lots of things to consider. I think that's my last slide, so we can go ahead and do the polling question for my section. All right, excellent. So what is the most common second cancer in retinoblastoma patients? And the majority of you selected retinoblastoma, or selected osteosarcoma, excuse me, which is correct. And with that, I'm going to hand the screen over to Kim Mayer, who is our retinoblastoma nurse coordinator, who's going to talk about some psychosocial aspects of care for these patients.
I am going to speak to you about the psychosocial aspects of retinoblastoma and how it affects the child and family. The diagnosis of retinoblastoma, as you can imagine, is an intense, can cause intense emotional distress to the family and patient, depending on how old the patient is. It is extremely stressful to them. Sorry, why is this not? Okay, there we go. As it was discussed, retinoblastoma can begin while in utero or at a young age, but it can have lifelong effects on the individual. Retinoblastoma can have emotional and psychological effects on the child and also on their families. For the child or children, treatment for retinoblastoma can disrupt their education, their social, cognitive, and physical development, and these can lead to emotional distress, significant levels of depression and anxiety, and concerns for their morality. For families, a diagnosis and treatment can be extremely stressful, as I've mentioned, and this can lead to a severe anxiety and stress for them, along with depression and grief resulting from changes in their family life and what their normal used to look like, but also watching their child go through treatment. It can also cause fear of what's unknown, and if their child will suffer from any vision loss, will the chemotherapy actually work? Will their child need enucleation? There are social and behavioral challenges that may occur with retinoblastoma, and some of these examples are social isolation. Children may struggle to engage with their peers during and after treatment, especially if they suffer from vision loss or have physical changes related to their treatment and therapy. Behavioral problems may also occur. Some children can experience behavioral issues such as withdrawing or aggression due to stress and trauma associated with their illness and treatment. Oh, sorry, let's see. The family dynamics can also become a challenge. RB can put a lot of strain on the family dynamic and their relationships and social activities as families struggle to cope with the emotional and physical demands of caring for a child with cancer. The family has to adjust to what the new normal is. They might have financial issues, trying to work while caring for, their child who is sick and wanting to be there for them. The family and home responsibilities might change compared to what they're used to. Many families have other children that they need to care for, or they need to find someone to help care for those children while the other child is going through treatment. There's a need for specialized support with an RB diagnosis. As mentioned by Dr. Liberio, retinoblastoma programs often utilize interdisciplinary team model that includes medical specialists such as a pediatric ophthalmologist, ocular oncologist, geneticists, nurses, nurse practitioners, pathologists, occupational therapists, low vision specialists, social workers, child life specialists, just to name a few of the large team. All these people provide comprehensive psychosocial support to these patients and families. Psychosocial interventions include counseling, support groups, and therapy, which can assist patients and families cope with the emotional and social challenges of retinoblastoma. Having a family centered approach to care is essential, and recognizing that the family is an extremely important part of the child's therapy and treatment and recovery. Support groups, having support groups can provide a valuable opportunity for patients and families to connect to others who have gone through similar experiences, or just to have someone else that they can speak with that might share the same feelings and concerns. And this slide is just a collage of what makes up our multidisciplinary care team that I had just mentioned. There are several stages of psychosocial support. The first stage is diagnosis, and this is when the family and the patient, depending on their age, are coping with the new diagnosis, and they go through a grieving process. And this includes the 7 stages, which are shock, denial, anger, bargaining, guilt or depression, and finally hope and acceptance. And there's no timeline for these stages, as everyone grieves on their own pace. Understanding and allowing these feelings to happen as they need to helps the child and the family adjust to the retinoblastoma diagnosis. Treatment, providing education, and guidance about the diagnosis and child's treatment plan is very important. Having communication between the patient and family and the healthcare team to provide support is very important. And preparing the child and family for what's to come, meaning visits to the hospital, clinic appointments, tests, procedures, and different medical treatments such as eye exams under anesthesia, the chemotherapy, possible enucleation surgery, and visits to the ocularist for prosthetic eye fittings if necessary. And then there's child development and education is the third stage of child development, and making sure the child is supported and their needs are being met at school, and that they have vision support services is very important. And making sure to understand the child's visual acuity and functional vision needs to be addressed. Families learning how to talk to their child as they get older, talk to the school and community about retinoblastoma, vision loss, and an eye prosthetic if it is necessary. And the last stage of psychosocial support is treatment and survivorship. And intervention needs to be tailored to the specific needs of each child, making sure to connect families to vision services that will help the child in early intervention programs, speaking with the school district, vision services, providing resources for peer support groups, and finally referring families to a survivorship program. These are just a few of the assisted devices that are available for individuals with vision impairments that can be used at home and at school. And then the long-term impacts on patients with retinoblastoma. Even if their treatment is successful, survivors can experience long-term psychosocial challenges. And these can include anxiety, fear of reoccurrence or secondary cancers, as was spoken about or discussed previous to this, difficulties with emotional and social functioning, body image disturbance due to visible effects of therapy. And these would include like enucleation or physical changes resulting from radiation therapy. But having a multidisciplinary team approach when caring for our RB patient is very important because it provides comprehensive care and support to the family and to the patient from the time of diagnosis through their treatment to the end of treatment, and then for long-term follow-up care.
Thank you very much, Kim. So I'm going to go over the questions that were put in our chat box, and thank you very much, everybody, for your attention and for the wonderful questions. So the first question was, what chemotherapy is on the patch, and how long does it stay, and is it removed? So the chemo plaque is currently only available as a clinical trial, so it's not available for all patient use yet. The medicine is topotecan. It is left in place for 6 weeks. On the clinical trial, it has to be placed in the operating room and removed in the operating room. Eventually, I think it will have to be placed in the operating room, but because it is a silicone sleeve, it could potentially be left in the eye even when the drug is all eluted. More to come on that. We are just starting phase 2 trials. The next question was, at what stage is chemotherapy treatment effective? And Dr. Becktell, please chip in as you think appropriate. So usually if it's a unilateral group E retinoblastoma, we usually will advise enucleation, or if there are high-risk features on imaging or on an exam, we would advise enucleation. Chemotherapy is still needed in those situations if they have pathological high-risk features. For a bilateral group E disease, we would sometimes try systemic chemotherapy because we don't want to proceed with enucleating both eyes. Otherwise, any tumor that's group D or less could potentially be salvaged with either systemic chemotherapy or intraarterial chemotherapy. So, Dr. Becktell, do you have any thoughts on that?
No, I completely agree. I think that can be a role in any group, A through DI. There's always the potential that chemotherapy can be helpful. I think that one of the trickiest parts about retinoblastoma is that there sometimes are 1 or 2 options, and a lot of it depends on where the tumor is and what the other eye looks like and kind of all of those pieces. But our goal here, our team's goal is to minimize chances of metastatic disease. And we focus on that because we know that outcomes, as I think both Dr. Aparna and Dr. Liberio highlighted, are really poor when we truly have metastatic disease. And so we try to optimize not doing that. So it's nuanced.
So the next question is, if the tumor is post-laminar, is it considered extraocular? It's not considered extraocular if it's post-laminar, but the cut section of the optic nerve is clear. On pathology, if the cut section is infiltrated with tumor, then it's considered extraocular. Post-laminar invasion is considered a high-risk feature and an indication for possible systemic chemotherapy, but not considered extraocular. Dr. Hopp, do you have any comments on that?
Nope, that's exactly how I would think about it.
So the next question is how to decide regarding IAC versus IVC in recurrent bilateral retinoblastoma. Which one shall we proceed with? Again, this really depends on if the recurrence is bilateral and what was the primary treatment. If the primary treatment was systemic chemotherapy, then of course you can try salvage systemic chemotherapy again, though the outcomes may be poorer. So if you have bilateral simultaneous recurrence, then you really have to see the amount of recurrence. If one eye can be controlled with just local laser or cryo, then you would do that and do intraarterial to the other eye. If one eye is very advanced recurrence with high risk, then you would enucleate that one, do intraarterial to the other eye. We as a group are not in favor of doing bilateral simultaneous intraarterial chemotherapy, but on one or two occasions, we have done a tandem intraarterial chemotherapy for recurrent disease. For primary disease, for bilateral primary disease, our go is systemic chemo to start with. And then if there's a recurrence, then we will do intraarterial chemotherapy. Dr. Becktell, your thoughts?
Great.
Yeah. So we don't like tandem intraarterial. We have sometimes done tandem intraarterial chemotherapy, but we don't like to do bilateral simultaneous intraarterial chemotherapy. But that again depends on center to center. It's what your multidisciplinary team feels is the best for the kid based on their experience. The next question was typed in Spanish, and the question was mainly about risk factors for environmental risk factors for retinoblastoma. I think they were asking if volcanoes, in areas with volcanoes, there can be any higher risk. As far as we are aware, there's no clear-cut environmental factors that can contribute to the development of retinoblastoma. The next question was about prenatal screening. What is the benefit of early delivery for babies with retinoblastoma? So in our group, we would deliver the baby. We don't deliver before 36. We will deliver after 36 weeks only if we have seen a tumor on ultrasound and the tumor has demonstrated that it is increasing in size. If we see tiny tumors, then we are doing weekly ultrasounds. And if it's not changing in size, we would still go to term and deliver. But if the tumor is showing a significant change on the ultrasound, then we would do early treatment. And the advantage is that sometimes those tumors are pretty small that we can just do local therapy like a laser or a cryo. So we're avoiding systemic chemotherapy if we are detecting the tumor very small. The next question is, what is done for a preterm child with RB1 pathogenic variation? If a child is born preterm, then we would screen the child as we regularly would. The screening criteria is almost weekly ophthalmic exams. If there's a family history of retinoblastoma, or if the retinoblastoma genetic testing is positive, then we also really use our optical coherence tomography, the OCT, to detect occult tumors that you wouldn't have seen otherwise on fundus exams. You can attempt to do handheld OCTs on kids awake. If not, you have to take them under anesthesia to do a good exam and to do a good OCT. Dr. Becktell, any comments about that?
No, I totally agree. And I'll just, the only thing I'll add too is obviously we can give systemic chemo to a newborn if we need to, but in so many developmental growth, feeding, like for all of the reasons, if we can if delivering a week or two early increases our chances for being able to control that tumor with local measures and not needing systemic therapy, it is beyond beneficial for early, the early development for that baby.
And then if the tumor is large enough that you can't do local therapy, we also have the option of just doing a carboplatin bridge. We won't use all 3 doses of chemotherapy, but we'll use just the carboplatin at a lower dose as a bridge till they can get the standard chemotherapy. The next question was about the chemotherapy on the ARED trial post-enucleation, and I think we're talking about the high-risk features.
Yep.
Uh,
Can
yeah,
I take that
go
one?
ahead.
Yeah. So I think, the question is, with that study, it wasn't necessarily a head-to-head, right? We just treated all of these patients with high-risk features. And that decision was based on historical outcomes where if you had optic nerve invasion or choroidal involvement, you had increased mortality, like as low as 50%, some papers even lower than that. And so there's no specific answer for what was the recurrent disease for those groups because they were never grouped together. But we believe that there is huge benefit of using this chemo preventative because we know the outcomes. It is much harder to treat if it comes back extraocular or metastatic. There are some diseases that I treat as a solid tumor oncologist where we say, well, we'll see if it comes back, then we'll give chemo because it's the same outcome, and this is not that. And so I absolutely believe that the preventing extraocular spread is leaps and bounds critically important. And this chemotherapy overall is very well tolerated and of course, everything has some long-term side effects. But I think when you're really doing the risk benefit analysis, giving chemotherapy to minimize risk of extraocular recurrence the outcomes of this study were remarkably positive in our minds, and I believe it is really making a difference.
So again, on the children's oncology group, there was no comparison, but there is an older study, I believe from early 2000s, that Dr. Honover and Dr. Shields had published. And in that study, they showed 4% chance of metastatic disease if chemotherapy was given, and 24% chance if chemotherapy was not given. And I think that was a landmark paper and the only one that did a head-to-head comparison from historical controls. And because of studies like that, I don't think we have any justification to do a randomized trial like Dr. Becktell was telling, because the odds are clearly in favor of giving chemo. So we got some positive comments about the presentation. Thank you for the same. The next one is intraarterial chemotherapy advice in what group of patients? So like Dr. Becktell was saying earlier, for a group D and less, we would consider chemotherapy. For a group E unilateral, usually we would go to enucleation straight. And then the question was the risk of CRAO. So the original papers show that 1/4 chance of ischemic complications after intraarterial chemotherapy. Now I would say it's less than 10%. And again, it's by modification of the interventionalist technique that can reduce the risk of ischemia. After intraarterial chemotherapy, follow-up investigation and how frequently patient needs to be seen. So usually post intraarterial chemotherapy, you're still watching the child very closely for recurrence. On the therapy, we are doing weekly CBCs. Afterwards, if the absolute neutrophil count and CBC has normalized, you don't have to do any more screenings for the CBC. But ophthalmic screening is as routine. We usually do every 4 weeks, at least for 3-4 months to show stability of the disease. And then slowly you can move it to 5 weeks and 6 weeks and henceforth.
From an oncology perspective, when they're done with their IAC, even when we're done checking CBCs or blood counts, we still, as oncologists, like to check in about every 3 months just to make sure that, when we think about long-term side effects, there's not a ton from IAC, but we think it's really important that no matter what where or what chemo has gone in your body, that you have long-term oncology touch points as well while, you're still getting your eye exams.
Dr. Becktell, you want to take the next question? It says, for child less than 6 months old, do you give JO regimen or JOE? I think they mean vincristine carboplatin or vincristine etoposide carboplatin.
Yeah, so I think that we have done both. Is the kind of short answer. I think that with supportive care, giving chemotherapy to babies even under 6 months old, we've really been able to do that with that in a way that is very well tolerated when we give 3-drug chemotherapy. I think a lot of it depends on the group of the eye. So a group B eye in a patient less than 6 months old, I think we would see if we could get disease response with 2 chemotherapy regimen only versus a group D eye in a patient less than 6 months old. I think we would consider giving all 3 chemotherapy medications because we know that we can do it safely.
And also there's an older children's oncology group trial that was suspended that gave only vincristine carboplatin because they were seeing more recurrences. So
we try to give 3. We know we can do it safely, but there's, I think there's scenarios of lower group eyes in babies where 2 drugs are probably appropriate.
The other thing that Dr. Becktell and our team has also done is instead of giving 6 cycles for a group B or lesser eye, we've done just 3 cycles and seen how the response has been. The next question is, what is the difference between tandem IAC and bilateral simultaneously IAC? So bilateral simultaneous is on one interventionalist sitting. They are going and catheterizing both the eyes and delivering chemo. Tandem IAC is where they will do one eye and then 2 to 3 weeks later, they'll do the other eye if the ANC is normalized, and then the following cycle, they go to the other eye. So you're not giving simultaneous IAC, but you're going back and forth between the 2 eyes. Both are not our favored approaches. If we are in a corner where we have no other options, then we have done tandem IAC, but we do not like to do simultaneous IACs. The role of the pharmacist in the management of retinoblastoma, that was the next question. Again, very, very critical, be it for systemic chemo, intraarterial chemo, intravitreal chemo. I would say systemic chemo pharmacists are very used to doing, but when it comes to the intraarterial and intravitreal, the pharmacist role is extremely critical. And if you or your center are looking to start a program with intraarterial chemotherapy or intravitreal chemotherapy, I would advise that the pharmacists get involved very early because, again, the mixing of the drug is very important for intravitreal, especially if it's melphalan. It has to be mixed right before you have to inject. So again, very, very critical role. Next question is it effective to produce intravitreal chemotherapy for retinal peripheral seeds? Yeah, so for peripheral subretinal seeds, we usually try to do laser or TTT or cryo first. And like I showed in that image, if it is not controllable with local, then we have used high-dose topotecan to control those peripheral seeds. But again, you have to be very careful if it's a peripheral seed that you are far away from that region when you're injecting. If it's a peripheral vitreous seed, again, you would treat it with intravitreal chemotherapy. But again, you have to be very careful that you're not going in the quadrant where there's a recurrent disease. Next question is, OCT detects occult tumors. What is your area of focusing when performing OCT in children with no obvious tumors? Do you focus on the disc or macula or just random retinal spots? Excellent question. So with the OCT, as far as your handheld OCT can get, we will use it because it can detect occult tumors. If we have a peripheral small tumor that you see, then we will try to get the OCT on top of it. But supposing you have a familial retinoblastoma where you don't see active disease, in those cases, you're usually looking at the posterior pole area because in a newborn child, that is the that is the area where maximum new tumors will develop. So based on the situation, supposing you have a small tumor that you are monitoring, then of course you would do OCT on top of that lesion itself. Have you experienced cases where children are abandoned because of the diagnosis? Fortunately, in US, we do not see that as much. I have had situations where families did not show up for chemotherapy because they didn't believe in the treatment, and we have had to get I can't find the name.
Child Protective
Child
Services.
Protection Services. Yeah, we have to get Child Protection Services involved. I have on occasion even involved the hospital ethics board to intervene when we don't have good follow-up. I know that is a significant concerns in some other countries, and I think you have to find local solutions that would work. Because untreated, it is a fatal disease. So you have to find ways to somehow encourage these kids to come back. And again, thank you very much for the compliments. What is the role of the optometrist? I think they have a very important role to play in the screening and long-term management of retinoblastoma. Like we were speaking before, the red reflex exam, detection of tumors, and I think optometrists have a huge role to play in that. And also long-term care, be it, Kim was talking about ophthalmic follow-up, glasses, patching, and all those situations. I do not see any other questions come up. We will... the role of the orthoptist. So orthoptists are people that do strabismus measurements, and we actually have multiple orthoptists in our pediatric ophthalmology clinic, and they are very useful, especially when you have to do strabismus measurements, either post-chemotherapy or post-intraarterial chemotherapy. Intraarterial chemotherapy has shown multiple extraocular muscle effects, so they are very useful in that. The other role I think orthoptists could really play is in middle income and low income countries, where they could again drive the red reflex exam, screening, maybe even potentially family history of retinoblastoma, really drive that screening strategies. This is a question about observership in pediatric oncology. I'll let Dr. Becktell take that question, if you don't mind.
I'm not going to be a helpful person here. We don't do those here at Children's Wisconsin currently within our group. And I know that some of the bigger children's hospitals that has been a little bit more of a where I have seen that type of program. But I don't have personal experience or recommendations for that.
So even if you want to email us, we can put you in touch with some other places that have a global observership program. We do have a global department at MCW, but we are not currently offering observership in pediatric oncology. But if you can email us, we can put you in touch with other places that do the same. Okay. Thank you very much for attending, and we will be attaching a handout sheet with some of our chemotherapy protocols and pathology protocols. If any questions come up, feel free to email us with any questions or comments. Thank you very much.